Right. Welcome to Way2PACES, one of the free sessions. Today it's about Station 5, brief clinical consultations. So there are a few things in Station 5. So one is, as usual, we need to have the base knowledge of about what is going to happen and what are the things in terms of differential diagnosis, what are the key questions we can ask. Those kind of things would be there. And the other thing is, after knowing the knowledge, and the next is the clinical skills. When I say clinical skills, that's about doing the examination part, which is relevant to the problem or the symptoms. So two things over there. And also to get the differential diagnosis based upon the clinical knowledge as well as the clinical examination, and discussing with the patient. Patient concern is the main thing here, and also discussing with the examiner about the points over there. So we need to have a clear structure in our mind to approach this station, because it's a very quick one. And after all these like a knowledge, skills and concerns and differential diagnosis and explaining to the examiner and answering examiner's questions, there is a great deal of a time pressure here. So we need to be doing like this quickly. To do that, people does different things, or people do different things. And in terms of time management, say some people combine history and clinical examination at the same time, and they will examine and start asking questions. But some people can't do both at the same time. They do history first and then examination and then a catch up and concerns and with the questions with an examiner. So what, in my experience, sometimes people find to combine both tricky. For those people, there's a separate strategy. For people who are not comfortable in joining the examination and history at the same time, who want to do it separately, I would say, let's say the first 2 minutes for history and then 2 minutes for examination, 4 minutes gone, and the next 2 minutes you can catch up whatever we have left something in the history, or we want to check with the examination, we can do that. Then 6 minutes gone, and the last 2 minutes with the patient's concern, like 8 minutes, and then 2 minutes with the examiner answering questions. So I would say 2 minutes for history, 2 minutes for examination, 2 minutes for catch up, which we miss anything, we can catch up those things, and the final 2 minutes of the 8 minutes patient concerns, and the last 2 minutes with the examiner answering questions. So if we take this pattern, literally 3 minutes for the history and 3 minutes for the examination. When I say 3 minutes, when you people practice for the Station 5, I would say bear that in mind. See, when you practice with your study partner, you don't have the science in front of you. So we need to practice in terms of history. With the history, 3 minutes. So for example, 2 minutes history, and then with the 1 minute like a reminder, and then wind up with the 1 minute, then answer the concerns, then examine the questions. I know we can talk about like the examining signs and all, but that sometimes it's a bit tricky. For some people it's very tricky, because acting artificially to say that, oh, I'm examining the heart now, I'm examining the pulse, then you expect your friend or the partner to say 90 per minute. Are they regular? Then you would say, no, it's irregular. So again, when you do that, as the real exam pattern, the time, we are wasting our time in talking, because in exam, nobody is going to tell this. So we need to practice a bit more cautiously in terms of ideal situation is practice with the patients who has got signs or without signs, or everything is normal, how do you approach kind of thing. But don't try not to mix with different things actually. So now with the scenario, I just want to ask, is anybody interested in doing a role play? Because I've got few scenarios in the similar pattern about the history taking. Anybody interested to do the role play? I'll give a few seconds before getting an answer. Right. The no answers. Okay, then we can make it as a discussion. And while discussing, it would be helpful if people contribute either via chat or by their voice or anything. What do you think the differential diagnosis, what do you think you are? So I would like to share our PowerPoint with you all. Okay, this is about brief clinical consultation for PACES exam, and I'm Dr. Ramesh Turlava Venkateswaran.
Way2PACES, the right way.
Yes, way to PACES is the right way to PACES. And now, approach to station 5. So when there is a time pressure, and then with the different things about you have to combine clinical knowledge, clinical examination, and then come to a conclusion about differentials and ask about the examiner in terms of like explain and answer the questions. So we need a structure. There'll be a great confusion sometimes in terms of what to ask, what not to ask. So this is from like Royal College of Physicians suggestions in terms of these are the bare minimum they expect. So history of the current problem. When you say history, the first thing is about duration to say whether it's acute or chronic. Then you need to go into the symptom proper. We need to say whether any emergency is associated to that problem. Then the next thing is about symptom analysis. You have got some few diagnoses in the mind and then ask about relevant questions. In past medical history and past surgical history, current medications with allergy status is very important because when you're planning in terms of giving medications, we need to find out the allergy. We can't give the same medications over there. And relevant personal, social or travel history and occupation as such as well. So now going to the first scenario. 30-year-old Claire Burns has headache. So anybody wants to tell about anything or shall we continue the discussion? How do you approach? What are the things you ask? Anyone wants to tell? Okay. Right. As we say, in terms of first, we need to ask in terms of symptoms. There is a headache. And headache by itself is a very big topic. So we need to shorten in terms of the time to get a key answer for the key questions. So when we talk about headache, the first thing first is the duration, whether it's a short term, acute, hyperacute or long term. That itself will tell us. See, let's say for example, patients tell the headache is 3 weeks and sometimes they may say 3 weeks is getting worse. So we need to have a clear-cut duration in there to say how long you're having. When did the first time start? When did you notice? So how long you're having this problem? And then people can say, I'm having this for 6 months, but the last 3 weeks is getting worse. Then you know we are dealing with a chronic problem. It's not an acute problem. So that's the first thing. Then about a little bit more about the headache. So where is it? Is it the front of the head, the back of the head, sides or over there? It's like a tight band. That's the next thing. And immediate thing is about like associated symptoms. We usually ask in terms of like anything triggers the headache, like a flash of light or loud noise or chocolates or anything. If it's a female patient, here it is a female patient, it's like does it tie up with the menstrual period time? And we can ask all those things. Then it comes into the character of the headache and how severe the headache is. Associated symptoms, yes, you can ask nausea, vomiting. And if you're thinking in terms of like a neurology related headache and intracranial tension, you can ask about the weakness of the arms and legs and any problem with the speech and different things we can ask. So by this time, we need to stop and then go back to past medical history, because past medical history will give a big clue in terms of where to go sometimes. So if we miss the past medical history and then dig the questions again and again, it's a very vast region to cover. This is not full history taking. We need to bear that in mind. So in that case, come back to the past medical history, and depending upon what the past medical history is, say if the patient says, for example, history of migraine, then you know exactly what we're dealing with. So it could be history of migraine, whether the same migraine or different headache or anything else going on. Then in terms of like relevant history, personal and things. So we have to ask about the personal history. Invariably about the smoking and alcohol is a must. And then depending upon the relevant cases, we need to ask about like a sexual history and things and all. If relevant, we need to ask. And again, in terms of, let's say, if the symptoms is a fever and things, we need to ask about the travel history. But in this case, it may not be that relevant. The next thing is about medications and allergy, and about the type of medications. If the patient is already having certain types of medications for headache, you know what we are dealing with and then how long they are using, and then we can come to a conclusion about what is what. So with that in mind, let's say in terms of past medical history, without going into the past medical history, we need to have some differential diagnosis in mind. So this is the one I will ask you all to make a note in those 5 minutes. So let's say, for example, 30-year-old Claire Burns has headache, and then you need to think of the differentials at this time and then write a note in terms of these are things we need to ask. See, anytime, any symptoms, don't forget about emergencies. Headache, increase in intracranial tension or pressure, that's a common thing. And in females, there are so many causes, like a cerebral venous sinus thrombosis and etc., depending upon what the history is like. So that's the main thing you don't need to forget. And then the named headache in terms of like a migraine, tension, cluster, we need to ask in those simple terms. So for the station 5, if we have 3 concrete differential diagnoses to be excluded, which includes the emergency or urgent diagnosis, that's enough. So it's not like a history taking, you need to have like a, even in history taking, I would say like a 5 is enough. 5 concrete, I'm not talking about like a irrelevant and the rare, I'm not talking about that. So those 5 differentials should be a concrete, clear and relevant should be there. I'm not including irrelevant diagnosis in there. So my suggestion would be to have a 5 concrete diagnosis in mind for history and then at least 3 concrete diagnoses for station 5. So in this case, let's see what are the possible diagnoses here. Anyone wants to tell anything? Possible diagnosis, how do we go from here? You can give it a try. You can even chat if you want. Right, okay. So we'll go to the next slide. So again, these are the things that I always told is a benign. The first thing is a benign or something is a malignant. When I say malignant, it's not about, need not be like a malignancy or cancer. Then you can say in terms of whether it's any like a rise in intracranial pressure going on, for whatever reasons. And that's the other thing. Then that includes like a subarachnoid hemorrhage, anything like a thunderclap or clap thunder headache, severe, like a most severe in the back of the head, and that clues we need to go for. And also systemic condition. So systemic condition comes under past medical history. If people say anything, that's a big clue. If people don't say anything, we need to dig in something related to that. So let's say, for example, like a connective tissue disorders. If you see someone with the joint problems and then with the malar rash and things, you know we are dealing with SLE. And SLE with a headache, then you can say in terms of CNS related SLE or something like that. So the observation will give us a clue. We are not talking about examination skills here. The mere observation will take us to the past medical history even before touching the patient, even before asking the patient. That is observation power we need to develop for the exam and for the real scenarios. So I would say is a cluster or migraine or tension or anything related to rise in intracranial pressure, including subarachnoid hemorrhage, and then systemic condition. That's what I would say we need to go through. Next scenario, 66-year-old Helen Davies has collapsed at work. Anyone wants to take this as a scenario and suggest about what are the possible diagnoses, or do you want to make it as like a 3-minute history taking? That would be okay. Anyone? Okay, we'll carry on with the discussion. So in this scenario, it's a collapsed at work. So again, the basic rule is when, what happened. See, when there is something happening, for example, like a nausea, vomiting, headache and thoughts, you need to take about the duration. Duration is a must in those cases. Again, when something happened, like a collapse or like a dizzy and then fall, the most important clue we get it from what happened at that time. So what they are doing, where are they? May not be elaborate, but people will be trained to do that. So people won't talk about like when I was in the morning, they won't talk about that. They will come to the point straight away because all the surrogate will know there's no enough time with us. So that's when you say collapse work means. So first of all, we need to talk about what is the collapse? Where is it? So that's where we need to talk about in terms of collapse. And the other thing, when we talk about the differentials in mind, that the first thing is about neuro or cardiac. Again, cardiac, we know everything in terms of either structural problem with aortic stenosis kind of thing, or anything like a HOCM, or anything like a heart failure causing any problems, making dizzy, or the commonest one in terms of arrhythmias. And in terms of arrhythmias, you can take like a brady, tachy, and with the tachy, we need to go in terms of like AF, atrial fibrillation. That's the commonest one. The commonest presentation with the infection is the AF. So when people say collapse at work, and again, is it related to AF? Or when you know that it's related to AF, then you need to go towards the triggers for the AF. Like what are the reasons? The commonest reason being infection. So we need to tackle that. The arrhythmias is the big chunk, is the first thing. Next thing is about the neurology. And again, when we talk about neurology, so we are dealing with the different things. And collapse like a seizure, and then is anything like a TIA, or as people presented with the collapse because of the weak arms and legs and suddenly dropped on the floor, something like that, then we can know where's any weakness and is it like a stroke. So anything we can get a clue, like a neurology in this case, the collapse. And the third category is like a syncope. And again, if you're talking about syncope, clear cut in terms of what about the pre-syncope or syncope, and then added to the neurology, I'm just adding on like a seizure. Also, we need to bear that in mind. And the last one in terms of like a situational syncope. And the situational is what we are talking about, like what we are doing at the time. So again, it's like a micturition syncope, defecation syncope, cough syncope, there are plenty of that. So we need to talk in that angle as well. So now you can get a conclusion. So the 5 minutes, we can say, oh, these are all the possibilities, and then make a note of it. There'll be 2 scenarios, there won't be 1 scenario. So you have got only 2.5 minutes to work it through. What are the possible differential diagnoses in this, like before entering station 5. So ideally, let's say 2 minutes for the first session, write the differentials, and the 2 minutes for the next session, write the differentials. Then when you go to the patients, not to forget those. So again, collapse here, anything, the emergency things can happen, like a AF, fast AF, tachy, anything can happen. So we need to ask in terms of what is going on first, and in terms of duration, this is the first time, what has happened before, and moving on to past medical history. We know if there is any medical history, we know what's going on, and medications, allergy. And as I said, personal history is the past smoking, alcohol is mandatory. The other things you can add or delete depending upon the situations. So when you talk about all these things at the end of the thing, you need to have a differential diagnosis, as I said, at least 3 concrete ones. And then we have to explain in terms of patient concern, this is what I'm thinking, this is what I need to go for a test, and this is where we need to go in terms of, and the other thing is into not only this term, all the other things. The next big decision is, are you going to keep them in the hospital, or are you going to send them home with the investigations as OPD, outpatient department, or outpatient clinic as well. So that we need to design in terms of what is the plan. The plan comes from the differentials, and with the differentials is like an investigation. Obviously, you're going to examine and you get a clue. Sometimes you get a clue, sometimes you won't get any clue in the examination. Half of the time, surrogates will not be having any signs, but you need to work out the symptoms, what's going on with that. So now with the differentials, again, we are talking about like a cardiac, arrhythmias, and structural problem like aortic stenosis, and neurology, which is like a seizure. I think I've covered everything. Situational, postural, yeah. I didn't cover initially the postural. Postural is also important. And that again, in terms of like say, started on doxazosine, like last week, and then after taking, now I can't stand up, feeling giddy, and then had a collapse, means you can relate it to any blood pressure medication or any, let's say, some of the antipsychotics can cause a drop in blood pressure. We need to have a clear cut in terms of, oh, this is what happening over there. Let's say, for example, amitriptyline. Somebody started on like a 10 milligrams amitriptyline for her neuropathic pain last week, and then having problems with the dizziness and had a collapse. Then you know what we are dealing with, postural, and then we need to confirm. And while examining, you can ask the examiner, I would like to do a postural blood pressure, and the examiner will ask whether there's a postural drop or not. We'll tell you the answer. And the last but not the least is vasovagal. Again, that's also related like a long standing. When I say long standing, standing for a long time, and also like, for example, like a very warm day, I was dehydrated a little bit, I didn't drink water so much, I went out and I just had a collapse. That means it's like related to vasovagal, might not be related to anything else. So that's where you need to unwind the scenarios bit by bit, and when you get a clue, you have to stop and then see how things go. When you know what's going on with the differential, then we can talk about the exam, examination would have done it already, and the investigations, and then a management plan, then answer examiner questions. The third scenario, 72-year-old lady or gentleman, let's say both, either of them is okay, a difficulty in swallowing, that's dysphagia, and the biggest clue here is gastroenterology team could not find any cause for investigations or any cause after investigations. So that's a big clue here. So when you talk about dysphagia, again, the differential diagnosis will be going to your mind. We need to talk about like oropharyngeal and pharynx, and oropharynx and the stomach. Then we need to talk about like esophagus. So it's a big thing, like a GI tract. But here it's clearly said after investigations they couldn't find anything, means say the usual stuff in terms of oropharynx, like a swelling or anything might not be there, like a block with the pathway. And then esophagus, there's nothing like esophagitis or like a stricture, and then the stomach, there is nothing there. So we are not talking about esophagitis, gastritis here, because it's clearly said there isn't much any GE things going on. So when you're talking about the dysphagia, if it's not the GE related cause, the gastroenterology, what's the other big chunk is the neurology. And we all know neurology, how to differentiate between this and that. And again, the starting point is how long you are having difficulty in swallowing, whether it's an acute or the chronic one. And acute and chronic will divide into different things like an emergency or non-emergency over there. And with the neurology, you can say which started first. It's like a difficulty in swallowing is the liquids or solids, and that way things will differentiate which one we are dealing with. The next question is, as I said, in terms of what is the main problem, and when you take it, where do you feel like getting stuck here? Can you explain me what the dysphagia is about? A difficulty in swallowing, it's getting worse, and associated problem. So let's for example dysphagia and then vomiting. So dysphagia, vomiting, there's completely a block in there, that's a different thing. And then people can say I have difficulty in voice, and then like a nasal regurgitation, somebody can say that. So these are the things will contribute in terms of, okay, the neurology, within the neurology, these are the things I'm looking for. So in neurology, what I'm talking about, like a weakness of the muscles of the swallowing, and when they are weak, and when I say neurology, something like a myasthenia gravis or a bulbar palsy, sort of a bulbar palsy due to stroke or due to MND kind of thing. And then we get a clue in terms of the post-medical history. So this is about the neurology chunk. The next chunk in terms of muscle or the muscular disorders, which is causing the muscle problem, like polymyositis. You can ask in terms of what's going on. Is it like a muscle problem or am I dealing with? Or is it like a scleroderma? As I said before in the previous case, if somebody is having like a pinched nose and tight skin, you know, oh, exactly this is what's going on. And the same patient as a dysphagia complaint, you can easily relate to what's going on. So that's where we need to work it out in terms of, so neurology is a big chunk, and then the muscle or like a connective tissue disorders affecting the muscle causing dysphagia, so polymyositis over there. And with the neurology, myasthenia gravis and all those things will come into play. Luckily in this scenario, the gastroenterology is not included, but if it's not given in the scenario, the dysphagia will have another arm in terms of oropharynx, esophagus and stomach. So that's where the structure will be important. 3 different structures, oropharynx and then esophagus, stomach, E. So entire thing is a GE, and the second structure in terms of neurology, and the third structure in terms of muscle or the systemic disorders or autoimmune diseases. So once you know the past medical history, they fit in one of the things. And again, with the personal history in terms of like a smoking, alcohol, yes, we have to deal with it. Medications, allergy, and the last one in terms of explaining things. Yes, as I said, in terms of that's the way you need to. So for each and every like a diagnosis, you can have like a one or two questions, or sometimes one question will answer everything. So myasthenia gravis, you can ask about like how is the difficulty in swallowing, is there any difference you see in the day and evening, morning and evening, how do you see as the day goes on. So if there is a clear cut, then we can say what's going on. If it is not, say let's say a patient gives history of MND already and affecting like a weakness of the arms and legs and no problems with the swallowing, suddenly there is a problem. That means you are dealing with a bulbar problem here. It's involvement of the bulbar, involvement of MND, and then you need to investigate properly to confirm, and then you need to refer to the neurologist, and the thing will go in that route. So we'll go to the next scenario. So again, 80-year-old Cecelia Thompson has a nausea and vomiting. So again, the biggest thing is nausea and vomiting. We need to know in terms of is it a GI, or again, we need to exclude in terms of increase in intracranial tension or pressure. That means a neurology. And again, other systemic causes for nausea and vomiting. When you say systemic causes, anything like, for example, other systems. So in terms of, let's say, the quick one or the easiest one is medication, the drug induced. Anything causes, okay, sort of an antibiotic for UTI and having problems with nausea and vomiting. We know exactly what we're dealing with. And when I say the whole part of the system is in terms of like autoimmune disease, presenting as nausea and vomiting, and neurology problem presenting as nausea and vomiting, we need to answer those questions in terms of, again, like a digoxin, short-run digoxin having nausea and vomiting, like a digoxin toxicity. We need to exclude all. So the key thing about nausea and vomiting is the medication is the important thing, actually, because some of the medications are exactly the reason for nausea and vomiting. The other thing I can think of in terms of, like, for example, any like a palliative cancer, having palliative chemotherapy, and some of the chemotherapies are well known to produce nausea and vomiting, and we need to see how things go in that. So the branch in terms of asking questions is, yes, first duration, once, yes, it's acute, chronic, what's going on, and then once you reach that, we need to clear cut in terms of whether it's a gastro problem or a neuro problem or something else going on with the medications. See, the common is even sepsis. A UTI can cause vomiting. Then we need to ask the commonest questions and infection, antibiotic, and everything over there to get a good go at the problems. By the time you're all about things, and we shouldn't forget the food poisoning things. That's the commonest thing in terms of, yes, the norovirus or the food poisoning. You need to know what's in there. Anybody else in the home got affected? Did you have anything like unusual food or anything? Do you think you're having like a food poisoning also? So the one key question, one question off. So again, the key important things is get all the questions right, do the relevant examination, and then see how things are, and then you can get to the conclusion about the differentials. And having the differentials, you can ask more questions in the past medical history and all, you get a different clue. So yeah, again, there's a big chunk in terms of celiac disease or IBD. There's a big chunk like inflammatory bowel disease or irritable bowel syndrome, IBS and IBD. So there's a big group. So if you go back to what are the possible things, and again it's here. The food poisoning already mentioned, infection, medication, constipation, that's the commonest cause. You can't give the clear analysis without asking bowel movements with the vomiting. Again, it's a clear cut, isn't it? Some the other neurologies, they are not included G at all, because again that would be a wide thing, but we can't exclude the reason for the nausea and vomiting without touching the GI. Again, constipation is there, so you will know the cause of the vomiting and things. Or actually migraine and things. If patient gets like I have a migraine, then you know, oh, that's related to nausea and vomiting. If patients say I have a cancer of the lung and having chemotherapy and suddenly I develop vomiting, means yes, GI is a possibility, but at the same time, cancer spread to the brain mets, it's also a solid possibility. And when I say the differentials, and that's what I say, with the symptom analysis, you might not get the clue, but at least you would have cleared the emergency reasons either in or out. The next bit, in terms of the past medical history, you get more clues in terms of where is it, what is on, and we need to see how things go. Then with the medications and things, by that time you narrow down your diagnosis and you've got key things, so 3 differentials in there. And sometimes you know that the first one is the most appropriate one, but you have to tell about the differential diagnosis, at least 3 with a clear-cut one, and then ask the examiner in terms of present the examiner. And in all the scenarios in station 5, the key thing is answering patient's concern. That's the most important thing. Say, for example, in terms of constipation, you diagnose a constipation based upon the history, and then the examination, the bowels are okay, bowel sounds are okay. So we are not talking about any bowel obstruction that are subacute or acute or chronic here. Then with the constipation, you may ask in terms of, and people will say, oh, I know I'm constipated, but when I take Docuzate, I vomit. That's a problem. So it's hard. Is it the constipation causing the vomiting, or is it Docuzate causing the vomiting? Then once you know the medication list and then whatever tried and allergy and things, you can say, okay, you tried Docuzate, that's causing nausea and vomiting, and we can try something else. And again, with the constipation, you know all its symptoms of 2 things. Either we are dealing with the frequency or we are dealing with the consistency. Hard stools, yes, it's a constipation, and less frequent stool, it's a constipation. Sometimes we have one, sometimes we have both, and we need to choose laxative based upon what's going on. So I would say all these like scenarios, get the scenarios ready and spend like 2 minutes before the scenario for one scenario. So 2 minutes for the station 5 first scenario and 2 minutes for station 5 second scenario. Make notes and get all the differences in your mind. Then when you go there, at least you know what you're dealing with. Then with the key questions, first of all, is a duration, any symptom, and if it's something happening like a collapse, you need to ask what you're doing at that time. Can you describe briefly? You can say describe briefly. If you say you want to describe, and people can start a big history and we don't have time for that. So that's the key. And then the past medical history, relevant history is important thing. And personal history in terms of smoking, alcohol, any particular thing about travel and things, if it is there, you can ask. If not, no need to worry about it. And after all these things, examination will give us a clue. Sometimes the examination might be normal. Then based upon the history and examination, get the relevant investigations, and then you can explain the patient as much as you get at that point. And that's the patient concern. Never ever forget to ask about patient concern. Whatever you do at the end of like 6 minutes, to stop and then patient concern, then 2 minutes wind up concerns and explain that this is what we're going to do it. Then ready for the examiner question. The last 2 minutes is a key. When an examiner have a well set of questions, what's the diagnosis or what's the differential diagnosis? What do you think? How do you investigate? So set questions, but the answers are different. If we know, like with the proper history and mini examination, we know what's going on, and with the clue, we set a plan and explain the patient and answer the questions. Then it's a straightforward through.
Way2PACES. The right way.
Right. I would say that's the end of the session in terms of like a PowerPoint. So when you're talking about, I will stop the share screen, doing something different. So any questions so far? Because I know we have talked about the questions and things, a different one. So we will see what is happening here. Oh no, I can't open the Zoom. There's something going on here. I'll stop the share screen first. Yes, now we are back. So any questions based upon the 4 scenarios or anything related to the structure and answering questions or anything from anyone? Right? If there are no questions, I would say practice well.
Hello.
Sorry. Hello.
Hello, Professor. How are you?
Yeah, I'm fine. Thank you. How are you?
I am fine, Dr. Ramesh.
Yeah.
Just in the ICU, the time for the family visits, but I didn't have a good news. That's why I just stay silent a little bit.
That's okay, no problem. So you can stay silent as long as you observe and make notes and put the learning into action. That's fantastic. That's not a problem.
Yes, I did receive my results, and hopefully it was good in the clinical stations. I would share it with you.
Dr. Nawar, Dr. Nawar,
Yes.
it's
Yep.
a live,
Mm-hmm.
so we can have another discussion. It's a live session going on. So I don't mind
Okay.
talking to you, but as long as you don't mind,
Yes. 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 Yeah.
it's okay.
Sure. That's fine. Yeah.
So maybe we can talk about separately in terms of what's going on when you're.
Yes. Yeah.
Yeah. Okay. Have any doubts or anything in these scenarios? Anyone?
Mm.
No, that's okay then. So I would say practice with the time, and then you choose whichever way you want to do it, history and examination combined or separate. But anything you were planning to do, maybe you can try different both and then pick the one which you are comfortable with. When you are practicing with a study partner, do real practice, and the timing is the key. So anything, give me a shout, any questions or anything, and then we'll take it from there. We'll meet you in another free session with the Way to Paces. Thank you. Best wishes.
Thank you.